Can we just have these front lines off so that screen can see these front lines? Yeah. Yeah. Thank you. So have you finished the breast? I mean, are you still continuing the breast? I mean, you have read the breast imaging. I mean, you need to know the imaging aspect. Okay. Okay, so Bismillahirrahmanirrahim. We have two lectures. We'll be just continuing after this pregnancy. This is the lecture related to pregnancy, and then we talk about the breast imaging. So we covered this last time, if you remember. We said we use ultrasound as an imaging modality when it comes to evaluating the female genital organs. So as we all know, we use two probes. One is this convex probe, or this is a low frequency probe. So if you were to ask me, when do you use this? I told you last time that you need a bladder in front. Okay. So how to differentiate between a convex probe and a transvaginal probe? We have to look at the image and see if there is a bladder lying in front of it. If you see a bladder lying in front of the uterus, that means we have done a trans-abdominal scan. It's not an internal ultrasound. Okay. So in this case, this is a trans-abdominal scan where we need a window in front. So the bladder acts as a window. So the sound waves easily pass through the fluid, and you're able to see the uterus just behind the urinary bladder. So you can make out the uterine fundus, you can make out the endometrium. This echogenic line is the endometrium. This part is the cervix, and obviously this is the lower part, which is the vagina. So you are able to see these only because you have this window in front of you, which is when you're using the trans-abdominal scan. The frequency in this case is around 4 megahertz, 4 to 5 megahertz. The good thing about abdominal ultrasound is that it gives you a broad picture. You will be able to see all structures. Like if you just go up, you will be able to see the abdominal structures. Likewise, you can go into the adnexa, look for the ovaries. But when you're doing the internal scan, you have a very limited field in front of you. So you're just able to see the uterus or the adnexa where you have the ovary. And if you want to go up, obviously you cannot, because the high frequency probe doesn't allow you to see structures beyond a limit. So this is the transvaginal probe, which has a long handle to it, but it has a better maneuverability to it. So you are able to sort of look into the internal organs in the pelvis much with more comfort rather than in abdomen. So you don't need a bladder in this case. As you see, this is not the bladder. This is just the image, the part of the image. So you are directly visualizing the uterus, which is in front of the probe, and you are able to see the endometrium. So if you look at this and look at this endometrium, so you get a magnified sort of view with a transvaginal probe, because the probe that you're using is high frequency. So the frequency is around 7 or 8 megahertz. Okay. So we discussed this last time. So just a sort of reminder before we go into the images again, because we are going to use the same sort of probe to see early pregnancy. That is the transvaginal probe, and we can also use the trans-abdominal probe for cases where the pregnancy is advanced, like in the second or third trimester. Okay, so when you're looking at the early gestational sac, this is what you see in early pregnancy. You are able to see a fluid containing black sac with echogenic line to it. So the margins of this sac appear echogenic or bright like this. And inside you see a black fluid. So this is the gestational sac that you see earlier on. You usually have the sac visible 16 to 21 days after conception, okay? And at the same time, this echogenic rounded structure which lies inside the sac is the yolk sac. Okay? Inside the gestational sac, you have another echogenic ring-like structure like this, which is the yolk sac. The yolk sac is usually visible around 5 to 6 weeks, okay? So the first structure that is visible inside the gestational sac is going to be the yolk sac. And if you look carefully to the side of the yolk sac, you might be able to see a tiny sort of pole, which is known as fetal pole, which is the early, the gestation that you see. Both yolk sac and the fetal pole appear around 6 weeks of gestation. Now, another thing to look for this sac is it has a double decidual line to it. What is a double decidual line? You have an echogenic line like this, which surrounds the sac, and then you have a low or hypoechoic area, and then you have another sort of echogenic line. So two echogenic lines alternating with each other. So this is known as a double decidual reaction. So in a normal pregnancy, earlier on, you should have a double decidual reaction, an echogenic inner line and an echogenic outer line. Okay. So you see there are two lines, this echogenic line and this echogenic line. So this is a sort of normal appearance for an early gestational sac. If you just see one gestational line like this, echogenic line like this, it is known as a pseudo-gestational sac. Does anyone have an idea when do you have a pseudo-gestational sac? In cases of? Okay, not exactly. It's more an endometrial reaction to pregnancy. So when you don't have an intrauterine pregnancy, so do you know a condition where you don't have an intrauterine pregnancy? Ectopic pregnancy. So in cases of ectopic pregnancy, you will not have a double decidual reaction. You will just have an echogenic line inside, which acts as a pseudo-gestational sac. It's the reaction of the endometrium when there is gestation. But this time the gestation is outside the uterus. So that is an ectopic pregnancy. We'll see examples of that. Okay, so as I've said, in the gestational sac, the first thing to look for is the yolk sac, which is a ring-like structure like this. And to the side of the yolk sac, you would see a baby, which is the fetus, the early on fetus. We call this as an fetal pole, or the embryo that you see around this echogenic structure that is lying just adjacent to the yolk sac. Both more or less appear around 5 to 6 weeks of gestation. Okay, another thing that is seen here is a fluid that is surrounding the gestational sac. So sometimes you would see hemorrhage around the gestational sac. So earlier on, sometimes there are chances of pregnancy presenting with PV bleeding, and sometimes the sac is sort of not fully implanted, and you would have some sort of hemorrhage around it. So this is known as subchorionic hemorrhage, which is just or perigestational sac hemorrhage that you see sometimes in early pregnancy. And then such cases are called as threatened abortion. So chances of abortion increases when this hemorrhage is more around the gestational sac. We'll see examples of this later on. So this is just to show you a diagrammatic appearance where you have a double decidual reaction, the inner echogenic line and the outer echogenic line, which is a feature of or appearance of normal pregnancy. Whereas a single echogenic line like this is a pseudo-gestational sac, which you would see in cases of ectopic pregnancy. Okay. And you should also look for myometrial mantle, which is the myometrial tissue around the gestational sac. Because if you don't see any myometrial tissue around the sac, then again, it is not inside the uterus. That means it's outside the uterus. Okay, another example of double decidual ring sign. Okay, so you have an inner echogenic line and an outer echogenic. So this is how the normal pregnancy would look like, double decidual sac sign. This is a pseudo-gestational sac where it mimics a sac, but it doesn't have an inner echogenic line like this. So this is a sac of ectopic pregnancy, as I was just referring to earlier. So always when you are looking for, when you don't have the yolk sac and when you don't have a fetal pole, you just see a black sort of, fluid containing sac inside, then look at the margins of the sac. Do you have a double decidual reaction like this? You should wait for the rest of the things to appear. And if you do not have a double decidual reaction like this, then you should look at the adnexa carefully. It might be a case of ectopic pregnancy. Okay, by sixth menstrual week, early embryo can be identified. As I've said, around 5 to 6 weeks, you would see an embryo, which would be a fetal pole, like you see a yolk sac here. And this is where the fetal pole is located, just adjacent to this arrow. Okay. So as the fetus grows, then obviously you are able to see all the structures. This is the head of the fetus, this is the abdomen, and here you start seeing the limb buds here. So how to measure the fetus or how to measure the gestational age in the first trimester? We use crown rump length. So what is crown rump length? We measure from the head to the buttocks, this area. So we put a cursor here and we measure it from here to here. So head to buttocks. The measurement here is for example, in this case is 6.9, and the machine automatically calculates the age for you, like 13 weeks, 0 days. Okay. So this tells you this fetus is around 13 weeks and 0 days. So the age of this fetus is 13 weeks. So this is the most accurate sort of measurement of the fetus. Okay. So if someone asks you what is the most accurate measurement, you would say in the first trimester, we will measure the crown rump length. This gives you the most accurate age of the fetus. Okay, this we have already discussed. Yolk sac appears by around 5 to 6 weeks. It is a ring-like structure within the gestational sac. And usually, if the sac is around 10 to 12 by transvaginal or by 20 millimeters in size, by abdominal scan, you should see a gestational sac. You should see a yolk sac. So that means the sac, if you measure the sac, if it's around 20 millimeters or 2 centimeters in size, by this time, you should see a yolk sac. If you see a sac which is larger than their surrounding gestational sac, and you don't see a fetal pole, then this is again chances of abnormal pregnancy. So this can be an abnormal pregnancy if the gestational sac is small and the yolk sac gets larger in size like this. So what is viability? Viability means that the fetus is normally growing and it's going to develop normally. So viability means we need to look for any cardiac activity inside. So this confirms that the pregnancy is progressing normally. So we have different possibilities. Either it is going to progress normally, or there are different types of miscarriages that we'll talk of later. And the third option is molar pregnancy. If you remember the last lecture, we discussed molar pregnancy. What is molar pregnancy? Yeah, abnormal fertilization between sperm and egg results in an abnormal sort of pregnancy where it can be partial or it can be a complete molar pregnancy. So we saw this. I showed you a few examples of this. So we'll go through that again. Okay. So we'll talk of all 3 of them again, so that we know what exactly we're looking for. So a viable pregnancy is an intrauterine pregnancy that has cardiac motion seen by 7 to 8 weeks. So you must be, once you see a yolk sac and a fetal pole, then the third thing to look for is any cardiac activity inside. So how would you check for cardiac activity? You put a cursor like this. This is known as the pulse Doppler. We can make use of the pulse Doppler. And these pulsations that you get on this, you are able to calculate the heart rate. So you see 170 beats per minute. 170 beats per minute. So earlier on in pregnancy, if you measure from this to this, between 2 cycles, this is the exact heart rate. So the early fetal heart rate can be measured with pulse Doppler. But if you look here, you will also see a sort of flicker inside. If you look, if this was cine images, you'll be able to see a sort of, heart flickering inside. So this is again a fetus. You see a yolk sac on one side. As the fetus grows, the yolk sac sort of decreases in size. Okay, so you are able to see the head of the fetus here. This is the abdomen, and these are the limbs. So gestational sac by 5 weeks, yolk sac and embryo or fetus by 6 weeks, and cardiac activity you must be able to see by 7 weeks. So this is how the sequence is. Okay, again, another example of crown rump length, which is the measurement that you do in the first trimester from the head to the buttocks. And here the crown rump length is 36 millimeters. So the machine automatically tells you that it is 10 weeks and 3 days. So this is the exact age of the fetus. Okay, another example of crown rump length. Here you are able to see the limbs much better. So obviously the age of this fetus is more. Another thing to look for around 12 weeks of gestation is knuckle translucency. So does anyone know why are we interested in the knuckle translucency? Genetic disorders. So chromosomal or genetic disorders. If this thickness is more than 2 or 3 millimeters, it is sort of telling you that the fetus might be abnormal. Then you need to do genetic testing to confirm this, like in Down syndrome and other cases, this thickness increases. So you measure this thickness from here to here. If it is more than, say, 3 millimeters, then it is suspicious for genetic disorders. Okay, so for around 12 weeks of gestation, you also have to keep an eye on this thickness or this lucency behind in the region of posterior neck or the posterior part of the head. Okay, so this was about the first trimester. So if someone asks you how to measure the age in the first trimester, the answer would be crown rump length. Okay, what is crown rump length? From head to the buttocks. In the second trimester, we have few more things to look for now because obviously the fetus has grown in size. So now we have the head that has developed. We also have an abdomen that is now larger in size. And we also have now the buds developing, that is the fetal length or the femur length. So BPD, biparietal diameter, head circumference, the circumference of the head, abdominal circumference, the circumference or the measurement of the circumference of the abdomen, and femur length is the part of the femur that is sort of visible to you, the bony part of the fetus, the bony part of the limb. So these all tell you, if you measure them, the machine automatically would tell you what is the corresponding age. These ages are average ages that they have calculated. These are already, they are fed in the system. So they automatically tell you the rough age, what is there. Like if you give the machine the femoral length of the fetus, it will tell you how much is, for this length, how much is the age. Okay. So let me show you examples. So biparietal diameter is actually between two parietal bones. This left and right parietal bone, so we call it biparietal. Between this parietal bone and this parietal bone, we measure from this outer part of this parietal to inner part of this parietal bone. Whatever dimension comes out, the machine automatically tells you the age. In this case, 4.5 is the biparietal diameter, and the age is 19 weeks, 6 days. So you see, even up to the days, it tells you it is what exactly is the age. So 19 weeks, 6 days. If you do the head circumference, which is measurement all around the bony part of the skull, this is 16.7. And machine tells you the age is around 19 weeks and 3 days. So you see, there is a difference of 2-3 days between biparietal diameter and head circumference. So sometimes they might be the same, but there might be a little bit variation of 1 or 2 or 3 days between the measurements. Then you take a sort of average age. We don't know because the baby is larger in size. So we have the other dimensions now, which we rely more, like the biparietal diameter and the femur length. So
is it for the age or is it to make sure that the baby is growing in good way?
It's for the age as well, and if obviously the measurements, if they are smaller compared to these gestational age, then you also have to look for maybe the baby is a draft. If the parents are of small height, then the femur size might be small in size. Or if there is a dysplasia where the bones are shorter, you might have to, then you have to look for the other bones as well. So it depends. Okay,
So this is the crown rump, yes.
this is what I'm saying. If there was a crown rump length, that was the more reliable age. If you go for, if you didn't do a crown rump length in the first trimester, then you have to rely on the second trimester measurements. And obviously, they are not that accurate as compared to crown rump length. As I've said, there might be cases where the femur length is small because the parents are short, or the femur length is long because the parents are very long, or giants. So there is a variability. These ages are average ages. Okay? So this is how the femur length is measured. This is the ossified part of the bone from the head to the lower part of the femur, the condylar region. So this, you make the femur straight like this, and there is a acoustic shadowing behind this pole like this, then you measure the femur. And here in this case, it is 2.4 centimeters, and the age is automatically calculated 17 weeks, 2 days. Okay. So there is plus minus few days, as I've said. And the reason can be because, yes,
So,
no, we do rely, if we have done crown rump length in the first trimester, we'll rely on that more. But if we haven't done that in the first trimester, and the ultrasound, the first ultrasound is done in the second trimester, then we have to rely on these measurements. Understand? If we have a crown rump length in the first trimester, then the age is going to be that. Then we don't rely on femur length. Okay. And the reason I've just told you that the parents' height can affect the measurements. So this is the abdominal circumference. This is where the umbilical vein and artery enter the abdomen. So we try to make the abdomen round like this, and we take measurement where the umbilical vessels enter the abdomen. So this is the circumference or the circle that we draw around the abdomen. And again, the abdominal circumference in this case is 13. So the age calculation is 19 weeks and 1 day. Again, abdominal circumference can vary. Why? If the fetus is in IUGR, it's growth retarded, obviously the abdomen will be small. And if the baby is sort of a diabetic mother, the circumference might be larger. So again, these are not that accurate in the second trimester. Okay, so second trimester, another thing to look for is the placenta, because now the placenta has sort of developed and it is attached to the uterine wall. So why is it important? Because the delivery mechanism or the delivery method is going to be determined by the attachment of the placenta. If the placenta is in the upper or mid uterine part, then we can attempt a normal delivery. If the placenta is covering the cervix like this, or if it's in the lower segment, then obviously we need to be careful because we cannot deliver the baby with the placenta attached in the lower part. The chances of bleeding increases, and obviously this placenta, which is covering the cervix, is known as placenta previa. Have you read about previa? So obviously you cannot deliver, you need to do cesarean section, you have to plan the surgery or delivery beforehand. And these patients also have third trimester bleeding chances. So you have to be careful. They have to be on, bed rest, or they have to be monitored carefully so that if in cases they bleed, the hospital is closed. They don't take that much time to reach the hospital. So, as I've said, the placenta might attach to the posterior uterine wall like this, or it might attach to the anterior uterine wall. It can attach anywhere. It's, wherever it attaches, as long as it is away from the cervix, lower part or lower segment, it's fine. Another thing to look for, if you're planning a cesarean section and the placenta is lower in the lower part, then you have to tell the surgeon that be careful, don't give you might be sort of, your incision might be just over the placenta. So the location of the placenta is important. Okay, so this is the case of 32-year-old, where she came to the ER complaining of 1 to 2 hours of vaginal bleeding. There wasn't any pain, so it wasn't painful. I mean, bleeding was without abdominal pain. And the fetal heart tone are normal, so heart rate is there, so obviously the fetus is alive. She's visiting out of town and does not have any previous records available. You are a medical student and decide to do a transabdominal scan, and what do you see here? Yeah, you see the bladder here, and you see this is the cervix. CX is the cervix, so you see the placenta is in the posterior uterine wall, and it is lying or partially covering the internal os, or it is covering the cervix. So chances are that the bleeding might be because of low-lying placenta. So placenta previa, as I've said, is usually presents in the third trimester with painless bleeding. Okay. So this is important. The history is important in this case. A painless bleeding in the third trimester, think of placenta previa, and then you do an ultrasound to see whether what sort of previa it is. So we have different types of previa. This is complete previa, where the cervix is completely covered by the placenta. Here, this is known as partial previa, where one or two lips of the cervix are covered up by placenta. Here, this is marginal or low-lying placenta. I mean, marginal means distance around less than 2 centimeters from the cervix. So this is marginal. And low-lying is when obviously there is a distance from the cervix. Okay, this is low-lying. So you do attempt delivery in cases of low-lying as long as the distance from the cervix is around 2 centimeters. But if it is covering the placenta like this, then chances of painless bleeding are there. So you have to be careful with this. Another scenario is when the third trimester bleeding presents, which is painful. So if there is painful bleeding in the third trimester, then the other option is placental abruption. So what is abruption? Separation of the placenta from the uterine wall. So that means that it is a separation, means the placenta is the attachment is sort of giving away. So there is blood or there is hemorrhage behind the placenta, between the uterine wall and between the placenta. So this hypoechoic area that you see, this is the normal placenta, which is bright or echogenic, and this is the uterine wall. This is the uterine wall. So you see a black sort of collection between the uterine wall and the placenta. So this is known as retroplacental clot, or you can call it placental abruption. So now why it is important? Why do you think it is important to know this? Yeah, fetal is going to be, the blood supply to the fetus is going to be compromised because the placenta is where obviously, the blood to the fetus is being provided to the fetus. So that means now the placenta is separating from the uterus. If it is a small sort of separation, the surgeon or the gynecologist would sort of observe and do a repeat ultrasound to see if it is increasing in size or has it stopped. If it gets worse, then obviously they need to plan a surgery immediately, because then the fetus is at threat in the third trimester. So then obviously the fetus will go into distress and you have to plan your surgery earlier. This is another example of placental abruption where you have painful vaginal bleeding. This is the fetus. In this case, this is the uterine wall, and you see this black hypoechoic area, and this is the placenta. So if you see any hypoechoic collection or fluid around the placenta in the third trimester, or even in the second trimester, you shouldn't be seeing this fluid collection around the placenta, then think of placental abruption. And obviously the patient would also present with vaginal bleeding. The management is fluid administration, as you already know, like any where you are losing blood. Emergency C-sections are cases of severe hemorrhage, where the hemorrhage is severe or the abruption is severe, you would require immediate C-sections. So in the third trimester, to remember, painful or painless vaginal bleeding. So this is the clue to it. The history is sometimes very important. And then you do an ultrasound and confirm what is the problem. Another example of placenta here, this is the uterine wall, very nicely seen. And you shouldn't be seeing any hypoechoic fluid around the edge or between the uterine wall or the placenta. If you see a collection like this, that means it is abruption or placental hemorrhage. retroplacental clot, all these names are the same. Okay, so does anyone know how many umbilical artery or veins are there? 2 umbilical arteries and 1 umbilical vein. Okay, good. So you see, we have this color Doppler of the umbilical vessels here. So what takes oxygenated blood and what takes the other? Vein takes the oxygenated blood and the other one desaturated sort of. So the vein and the artery are studied with the help of Doppler like this. So this is the arterial waveform. Why it is important? Because this tells us that the blood supply to the fetus is normal or abnormal. If you have a waveform like this, where you have a diastolic component, you see this is the diastolic component. This is the systolic component. The upper part, this is the systolic, and this is the diastolic component. So as the resistance of blood inside the umbilical vessels increases, you start losing this diastolic component. So the waveform becomes spiky. Okay, this is important. So the blood supply can be studied, this abnormal waveform or high resistance flow inside the umbilical vessels. It tells you that the fetus is not getting adequate oxygenated blood, and the fetus is going into distress. And obviously, when you don't get the oxygenated or nutrients, the fetus will start developing IUGR. So one of the features to look for in cases of IUGR is also study the umbilical vessels. And the waveform tells you what sort of problem is there. If you have an abnormal waveform, where you do not have this diastolic component, it tells you that the blood supply to the fetus is compromised. Okay, we discussed this around 12 weeks or between 11 or 13 weeks, we try to measure the knuckle translucency like this. And I said, this is how the normal should look like. It should be less than 2 or 3 millimeters. If it gets thicker like this, then you should look for any genetic abnormality. In the second trimester, between 18 to 22 weeks, we also do a fetal anomaly scan. Why do we do this? Any abnormality, any sort of abnormality, we have to check for any sort of abnormality. So we are ready for whatever the consequences are. These can be sort of fatal anomalies. You see, there's a very long list of this. So you need to keep in mind, you have to check every part of the fetal so that you know what exactly is abnormal. Some of the anomalies can be left alone, like cleft palate, for example. It can be sort of left alone for later, where you can repair the cleft palate, like you have a club foot deformity. These are sort of benign, anomalies which can be corrected later on. But if you have a problem with the heart, you have a problem with the brain, you have a problem elsewhere, like I said, genetic problem, then you need to know, or you need to decide, because this is the time to sort of plan an abortion or terminate the pregnancy, the medical sort of termination. Okay, so this was an cleft palate deformity, and this is after correction. So obviously you let these children grow, because obviously you can correct them. Another example of club foot deformity, you can correct these deformities. Okay, sometimes you would see 2 fetuses or 2 sacs like this, and you see 2 fetal poles. So this is a twin pregnancy. Now, in twin pregnancy, the problem is whether they share the amniotic sac or they do not share the amniotic sac. Okay, so if they share the amniotic sac, then they are identical sort of twins. Okay, so they would have either male or female would be the same gender. So this is monochorionic, monoamniotic. That means amniotic means a single amniotic cavity, both share the same amniotic cavity. Monochorionic means the same placenta. They also share the same placenta, the chorionicity. So this is obviously identical twins. They both have the same gender. This is where the 2 fetuses have 2 amniotic cavities. You are able to see an amniotic separation between them, but they cannot share a single placenta again. The problem with monochorionic and monoamniotic is sometimes you would have problems with such pregnancy. So you have to carefully monitor them. Why? Because the placenta sharing can sometimes result in one fetus getting more oxygenated or nutrients and the other, sort of not getting enough nutrients and oxygen. So one might grow larger and the other one might remain small in size. So you have to keep on checking whether they are growing symmetrically or not. It depends on what sort of abnormality it is. Sometimes you cannot correct it. If a baby remains smaller, it's not growing, it's retarded, then, and the other one is growing normally, then you would sort of, try to, inject alcohol or something and just terminate the baby which is not normal. So you let the other one grow. So it depends on what the condition is. So sometimes you would also have conjoined twins. So what are conjoined twins? The twins are obviously monoamniotic. They share the same amniotic cavity. But another problem is, as I've said, they are also joined together. So where can they be joined? They can be joined in the head region. They can be joined in the abdominal part or in lower pelvis. So they can be sharing like the abdominal. Now the problem is, as long as they don't share the heart or they don't share the brain, they can be separated. If they share the brain and the heart, then obviously it becomes difficult to separate. Okay. Okay, so what is now, this was when we had a sort of normal gestation. So what is the abnormal intrauterine pregnancy? As I've said, if you don't see the yolk sac, you don't see the fetal pole, and the sac dimension is around 18 or 20 millimeters or 2 centimeters, then that means the pregnancy is not actually going normally, or it's not we suspect something abnormal in this. So you must see a fetal pole by 7 weeks, and by 7 weeks, you should also see some cardiac activity. So what are the different types of abnormal pregnancy? Blighted ovum or anembryonic. Anembryonic means there's no embryo. So you just see a gestational sac and the embryo or yolk sac is absent. Threatened abortion means it's a pregnancy that you see a fetal ball, you can even see a heart flicker, but the problem is you also see something abnormal around the sac, like a hemorrhage around the sac, or the cervix has opened up. So that means it is threatened abortion. Inevitable abortion means, now there is no chance. The cervix is open and sooner or later, the baby is going to come out. You have no way to stop the abortion. Complete abortion means you don't see inside anything, but there was a pregnancy, or you had an ultrasound done earlier where there was a pregnancy. Missed abortion means, anyone? What's missed? Yeah, you see a pregnancy. The only thing that you don't see is the heart activity. So if you see a baby around 7 weeks, you don't see a heart activity, then obviously the baby is dead. This is a blighted ovum, 3 centimeter sac, centimeters dimension sac. You don't see a yolk sac, you don't see a fetal pole, and then the sac also sort of becomes granulated or irregular shape. Okay, so this is a blighted ovum or an embryonic gestation. Threatened abortion, as I've said, if there is heartbeat tells you the pregnancy is still viable. That means chances are that very less than 10%, if there is heartbeat, very less than 10% chances of miscarriage. So once you see a cardiac activity, you are sure that 90% of the chance the baby will survive. So this is a gestational sac where you have hemorrhage around it. So it's a type of abruption where you have blood between the uterine wall and the gestational sac. So inevitable abortion. That means, this sac is not going to develop normally. And this is where the cervix has opened up. The fetus is still there, but it is sooner or later going to come out. So inevitable abortion. This is incomplete abortion where you see a sort of irregular or granulated, linear shaped sac inside the uterine cavity. This is an incomplete abortion, another sac inside, okay? And if the sacs remain small in size and you've done an ultrasound earlier which tells you it should have been this by this time, then again it tells you there the growth has stopped inside. You can also make use of color Doppler like this, and These are known as retained products of conception. So incomplete abortion means the sac or the placental tissue that remains inside. These are retained products of conception. Complete abortion, as I've said, you don't see anything inside the uterus, but you know there was a pregnancy either by doing pregnancy test or you had an ultrasound which was done earlier which showed pregnancy. Missed abortion is something like this, where you put color and you don't see any blood flow inside the fetus, or you don't see any heart activity here. So this means a missed abortion. Okay. Usually the reason for this is chromosomal anomalies. Okay, 50% of early intrauterine trimester spontaneous abortions are contributed to chromosomal anomalies. So it's by nature's way of getting rid of these abnormal fetuses. Ectopic pregnancy. So what is ectopic? You have the sac, instead of inside the uterine cavity, you have it implanted anywhere else. Majority, 95% of the time, they are implanted in the fallopian tube. 3% times they would be somewhere in the ovary. So it depends. Majority of the time, they will be around in the ampullary region of the fallopian tube like this. So this is where the sac. Now, how do you know this? This is ectopic. By looking at the uterine tissue or mantle that should be surrounded. If you don't see a uterine mantle tissue around it, that means this is ectopic pregnancy. Interstitial means somewhere here near the attachment of the fallopian tube with the uterus. So this is interstitial part. Okay. So with ectopic pregnancy, what you can see is a ruptured ectopic. Sometimes since it's implanted in the fallopian tube, and the fallopian tube is a very linear, small structure. So as the fetus grows, it can rupture this tube, and they present with rupture and obviously bleeding, and then it becomes an emergency to operate immediately. Definite ectopic means you are able to see the sac or a fetus or a yolk sac outside the uterus. Extrauterine empty gestational sac. Sometimes you are not able to see the yolk sac or a fetus, but you still see a sac that is in the adnexa. Or it can just appear as an echogenic or an adnexal mass. Pseudogestational sac, we already discussed. It's a reaction of the uterine cavity to the pregnancy, which is outside. You don't see the double decidual reaction. An empty uterus sometimes, and the pregnancy test, if it is positive, then you suspect ectopic pregnancy. So thick, brightly echogenic ring-like structure located outside the uterus with gestational sac containing obvious fetal fold, yolk sac, or both. So it depends on what you're looking for. This is the uterus. This is the endometrium. This echogenic line is the endometrium, and this is the ectopic pregnancy. Here you are able to see a fetal fold. So majority of the time you'll see like this, an echogenic ring-like structure, and if you put color inside, you see blood flow all around, the ring of blood flow all around. So the thing to look for is the uterus itself. So you see there is no uterine tissue around this. Okay, so this is an ectopic. Ruptured ectopic is when you also see blood inside the peritoneal cavity. Okay, and you have a appearance like this. This is the echogenic ectopic pregnancy. This is the ovary. You can see the follicles here, and around the ovary, you start seeing fluid around. Okay, so you don't see any uterus here. This is the adnexa. So this one is adjacent to the ovary. Obviously, the fallopian tube is adjacent to the ovary. So you see a ectopic sac here, and this is the ovary, and the uterus is somewhere here, and you start seeing blood inside the peritoneal cavity. So this is a ruptured ectopic. And if you put color around, you see that, as I said, ring of fire sign, you see flow all around the ectopic. Okay. This is known as tubal ring sign. This is known as tubal or ring of fire sign. We discussed this already. Intrauterine pseudogestational sac. It is not a normal sac. It's a reaction of the stimulation of the endometrium. Okay. It doesn't have the double decidual sac site, and beta-HCG is helpful in such cases. This is the pseudogestational sac, and if you look at the adnexa, this is the ectopic pregnancy. Interstitial ectopic, as I've said, it is close to the uterus. It's not in the fallopian tube, it's in some part of the uterus where it is, the fallopian tube is attached to it. So this is the endometrium, and you see some part of the myometrium around it. So this is the interstitial ectopic pregnancy. Again, this can be problematic. Okay, so this was a 42-year-old pregnant female with uterus large for size, hyperemesis gravidarum, beta hCG levels are high, transvaginal ultrasound shows hyperechoic soft tissue with cysts in the uterine cavity like this. Yes, I showed you this last time. So the third option that we are left with is now molar pregnancy. So what is molar pregnancy? We know that there are two types of molar pregnancy. One with no fetal parts, which is complete mole, and one is incomplete mole with partial fetal parts. Okay. So what do you do? You check the beta hCG levels. The beta hCG levels would be very higher as compared to normal pregnancy. The patient presents with painless vaginal bleeding, and sometimes they also pass vesicles. The uterus size is also larger for age. Okay. And what you see inside when you do an ultrasound is snowstorm appearance. Snowstorm appearance in cases of complete mole. Okay. Incomplete mole also shows a thick sort of placental tissue, but sometimes you would also see some fetal parts that are seen with them. So this is a snowstorm appearance. You see the vesicles or cysts inside the uterus. Once you do a pregnancy test, it comes out positive. The beta hCG levels are very much raised. The patient presents with hyperemesis, excessive vomiting, and vaginal passage of vesicles. So this is to show you a partial mole where you would see some part of the fetus and along with the vesicles or the snowstorm appearance here. So this is a partial mole. So this is another example of a complete mole transvaginal scan where you see inside vesicles. Not to mix this up with endometrial cancer. Obviously, in endometrial cancer, will be, not there will be no history of pregnancy. So what do you do when a patient comes with abdominal pain, vaginal bleeding? You do a pregnancy test and send the patient for ultrasound. If ultrasound shows an intrauterine pregnancy, you are assured, you send the patient back home. If the ultrasound does not show an intrauterine pregnancy, then you need to further wait and see what is going on. You can send in for beta hCG levels, or you can do, once the beta hCG levels suggest pregnancy, they are in the discriminatory zone, you can send the patient back home and ask for a follow-up after 48 hours. Okay, just to see if this might be an early pregnancy. If it doesn't turn out to be an early pregnancy, then obviously you need this. This will be suggested by the beta hCG levels that are done after 48 hours, and a follow-up ultrasound would confirm whether the pregnancy is there or not. So 60% of patients will have intrauterine pregnancy after follow-up. Rules out ectopic pregnancy. If you see an intrauterine pregnancy, then very less likely chances of an ectopic. But there are some cases where it is heterotopic, the pregnancy. So what is heterotopic pregnancy? Anyone?
What is the?
One inside the uterus and one outside the uterus. Normally, you don't see this unless the patient has ovulation induction. So there'll be history of ovulation induction. The ones who are artificially trying to get the ovulation stimulation. So the risk is in 1 in 30,000. And obviously there will be history of ovulation induction.
Doctor, so we have two pregnancies at the same time?
Yeah, you would have a pregnancy inside the uterus and you would have an ectopic pregnancy outside the uterus. So what would you do then? You will terminate this ectopic. So you will eject alcohol inside under ultrasound guidance and try to terminate. Sometimes if the fetus is weak, you can directly target the heart and inject alcohol inside.
Doctor, can you terminate the ectopic pregnancy without not affecting the intrauterine one?
Yeah, because you are not going to the other side. You just target the adnexa. So you can terminate this, yes. And at times the pregnancy, this pregnancy would progress normally. But you cannot leave this alone. Because this would rupture, then the other one will also be in trouble. Okay. So clear on this? Okay. So this was about, you can go through the references if you like. So I've tried to make it quite easy for you. You just have to go through these images once more and it'll all make sense. Remember, radiology is all about images. It's, you see something, you try to remember it, and you try to recall it again. It's just like ant meaning. So majority of the time, it's not that if you've seen it once, you see it once or more, and then it becomes more, the more you see, it gets imprinted in your brain. This is how, you can remember the cases. Okay, any questions on this before we move to the next? We try not to, affect the other one, but as you know, sometimes things don't always go, smoothly. As I've said, we try to, if we sort of stop the growth of the ectopic, and obviously that would, if that is sort of the fetus is killed, then the rest would continue. Understand? So that means we are trying to get rid of the growth of the ectopic pregnancy. We don't want the ectopic to grow. We just want this intrauterine one to grow. If we stop the growth of this one, then this would continue. Understand? It will atrophy. Yeah, it'll be there. The fetus will be lying to one side, it'll be there, but it will not grow in size. So it'll sort of atrophy. You might see some part of it after delivery. As I've said, we follow that protocol that I just mentioned. You do beta HCG, you send in for beta HCG or pregnancy test, and you do an ultrasound. That's it. Yeah, if the pregnancy test is negative, she's not pregnant. If the pregnancy test is positive, then you do an ultrasound. You do if on ultrasound it's an intrauterine pregnancy, you send her home and say, okay, rest assured, it's a normal pregnancy. If you don't see a sac, then you repeat an ultrasound and a beta HCG level after 48 hours and see if it is progressing normally or not. It should double by 48 hours. Okay, beta HCG levels should double, and you should see a sac after 48 hours. Okay, it depends on if it's intrauterine or extrauterine. Then you decide accordingly. Any other questions? It's not that difficult. You just, it's just simple. I think gynae and no, this is the easiest part.
We have Dr.
5 minutes.